The following podcast is part of a certified educational activity titled C3 for CLL, Community Conversations on Modern Care, Implications for Upfront and Sequential Management. Access the entire activity and complete the post-test at peerview.com/BFB860. Downloadable slides and practice aids are also available.
Good evening, everyone, and welcome to this PeerView live event, C3 for CLL, Implications for Upfront and Sequential Management. Today, panelists include myself, Nitin Jain from the Department of Leukemia, MD Anderson Cancer Center in Houston, along with Dr. Krish Patel and Dr. Megan Thompson. Krish Patel from Sarah Cannon Institute and Megan from Memorial Sloan Kettering. All right, so before we get started, so this just gives you a landscape of regulatory status of BTK and BCL2 approval in the United States as well as in the EU. As we know, we have the 3 colon BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib approved in the US, and they're also approved in the EU. In terms of the non-colon BTK inhibitor, pirtobrutinib, it's approved in the United States for relapsed refractory CLL, and most recently, it was recommended to be approved in the EU, which I think is expected, a formal approval is expected any day today to say. So that should be coming soon as well. And as you well know, BCL2 inhibitor venetoclax is approved in US as well as in EU. Now, I think one of the reasons this and other discussions are happening is that we are also, despite all the data, we're going to talk about BTK and BCL2, we also still see the use of chemoimmunotherapy. Now, this is an analysis of a Medicare Advantage health plan database in the United States, where they're looking at the patients with CLL who are getting first-line therapy for their CLL, and they're asking a question, what therapy they received. And as you can see in 2014, understandably, chemotherapy was the most commonly used regimen, followed by a BTK inhibitor. But even in 2021, you can see still about 20% of patients, 15 to 20% of the patients were still getting chemoimmunotherapy, which certainly should not be the case. So I think it's a matter of providing more education that we should really be moving away from chemoimmunotherapy 100% and using more and more BTK inhibitors and BCL2 inhibitor, either combinations or as monotherapy. So our overall goals for today is to help you understand the latest evidence and the guidelines supporting modern and emerging modalities of CLL, talk about how do we time-limited versus continuous therapy. We'll talk about target and cellular therapies, and then also discussion about some practical issues about delivery of care for CLL patients. Now, in this session, we are doing something kind of different than a usual, maybe the town hall sessions you have been on. We're going to talk about questions first. So there will be a question time first. We'll spend some time talking about the questions which you have already sent to us when you register for this event. So we'll talk about the question as a panel, and then we'll go over the slides supporting those kind of discussion points. And again, as I said, you'll continue to ask questions, which we'll see in our iPads here, and we can address those in real time as well, depending on the available time. I would also like to thank our partners, CLL Society, which has been helping patients with CLL for a long time. They have several resources for patients with CLL, and some of the things they do, many of the things, at least the patient support groups. They also have an expert access program, and they do a variety of educational events for patients as well as for physicians. They also have documents which you can provide to your patients, like a printed documents, education about CLL, CAR T-cell therapy, and other CLL treatments. All right, so as I said, we'll divide the talk into 3 different sessions. So I will start first talking about the frontline therapy in patients with CLL. All right. So as I mentioned to you before, we're going to do it a bit differently, where we have polled the questions you guys sent and the people in the audience in the online sent, and then we kind of group them into different groups to see what was the most important question was, and we'll kind of try to see our panelists' thoughts on that. So the most highlighted question for the frontline therapy was, how can you identify clear candidates for upfront therapy with time-limited BTK venetoclax? I guess presumably based on the AMPLIFY data, we're talking about uh, acalabrutinib plus venetoclax versus time-limited venetoclax plus obinutuzumab, and also the same question that since with the concept of continuous BTK inhibitor therapy versus time-limited therapy. So I will start first here. I think, certainly, as you know, the AMPLIFY data, which has come about, is likely going to lead to officially FDA approval, though it's already in the NCCN guidelines, acalabrutinib venetoclax plus minus obinutuzumab as a 1-year time-limited therapy. And certainly, so that adds the first time-limited therapy with the double oral agents, which previous to that, we only had venetoclax plus obinutuzumab. And certainly, we don't have a head-to-head data. We're waiting for the MAGIC trial, which will provide some head-to-head data in this regard. My personal view here will be, and again, I'm just looking at the 3-year data from AMPLIFY versus we have a much more longer follow-up with the CLL 14 study or CLL 13 study for that matter. But I think, to me, the efficacy-wise in the genomic different subsets mutated versus unmutated, I don't think I can say that one is definitely better than the other. So to me, it's more of a convenience issue or a patient preference issue. And I personally think that BTK-BCL2 doublet, especially the 2 doublet combination, would be easier to administer for patients and may sway a lot of patients, physicians to pursue that approach, with the caveat that we still don't have, obviously, 5-year, 6-year data with acala venetoclax. So I don't know if there's a specific one group of patients. I personally would say that they must get a acala-ven or they must get a ven-G in my view. But I will maybe ask Krish and Megan what your thoughts about this first question, and then we'll tackle the second question.
Yeah, I agree with you completely, Nitin. I think it comes down to the mode of administration and what that accessibility means to patients. I think sometimes they're in practice, right? There could also be cost implications for 2 oral medicines versus 1 IV, 1 not oral. So I think a lot of it is really driven to this point by patient data. And as you said, we're really looking to the MAGIC trial to help us answer the question in a prospective manner. So.
Megan, your thoughts about this?
Yeah, I totally agree with everything that's been said. I think, sometimes there's maybe patient-specific factors where maybe, for example, really bulky tonsillar disease or cervical adenopathy, where maybe there's a benefit of doing the BTK inhibitor first because you might get an infusion-related reaction with obinutuzumab. Or conversely, maybe a patient is on dual antiplatelet therapy and a BTK inhibitor is not the best fit there. So those patient-specific factors might sway you either way. But in the absence of randomized data and long-term follow-up, I think a lot of it does come down to the logistics and cost and patient preference.
And I think the second question about continuous BTK versus time-limited, which has been going on for a while, I would say that, I think my practice, I think more and more using time-limited therapies. And I think one important data set we'll review as well is the FLAIR study, which will be reported in about a couple of weeks at EHA, where they showed that 2 to 6 years of ibrutinib plus venetoclax improved PFS as well as OS compared to ibrutinib monotherapy. So the first trial, which is showing that this doublet is compared to continuous ibrutinib monotherapy, which is, kind of a perfect kind of a standard of care. So I think that and the data, I think most patients, long-term continuous BTK therapy add to the cost as well as hypertension, AFib. I think unless, I think in my view, patients who are like really above 80 years of age, significant comorbidities, issues in terms of travel to the center for TLS monitoring for venetoclax, certainly continuous BTK will still be a role there, 17P included. But I think quite a substantial number of patients in my practice, I'm already using time-limited therapy. And I think, again, as we discussed in the previous question, I think we will have one more choice for time-limited therapy. But I will ask Krish and Megan this important question before we move to the next one.
Yeah, I agree similarly with what you said. I think maybe one slight data gap we have in randomized studies, right, is what happens in P53 abnormal patients. They were not included in AMPLIFY. We do have single-arm studies that show us that, yeah, sure, fixed duration therapy can be very effective. Some was presented at this meeting in the Sequoia trial. So I think it's coming, and I agree with you, Nitin. I think for most people, time-limited therapy really is the way forward. I think maybe there are occasional patients who have very high-risk disease, biallelic loss of TP53, where you might have that conversation where we don't have the long-term follow-up, but we do for continuous BTK inhibitors. But I think it's just shrinking group of people.
Yeah, I agree. I think one of the things that's going to matter a lot is what does time limited mean? So you already mentioned, the flare data. It's not 14 cycles of therapy like Amplify. It's much longer and MRD driven. So I think that's something that not only will we be talking about time limited, but how do we define time limited? Do some people continue on the BTK inhibitor? Do they continue on the doublet? So I think that's one of the future directions that will go in the field.
Yeah. I think, but the overarching message, I think, would be, in my opinion, is that if you look at all the phase 3 studies practically right now, most of them are investigating time-limited, therapy. So I think the field of CLL, in my view, will move back. I mean, FCR, BR, different era, 6 cycles of treatment, you're done. Came BTK inhibitor, no, you need to take forever. Now we're dialing back. No, actually, can we do maybe some 1 to 2 years or some MRD guided? I think that's where the field will move. But let's move to the next question. These are kind of very specific questions. Do you ever modify the lead-in BTK dose when using a BTK venetoclax combination? Just to kind of clarify, typically BTK inhibitors are given for 2 to 3 months. Ibrutinib studies have used 3 months, Amplify used 2 months, really to cytoreduce before we add the venetoclax. And so all the studies have used standard dose of BTK in this context, at least for Acala and ZANU, and also the ibrutinib in the Captivate study and the GLOW study. So there's no need for dose reduction. And even in the doublet setting, when you're using the doublet with venetoclax, all the trials have at least started with the standard dose of BTK inhibitor. Now they may require dose reductions later for neutropenia and whatnot, but at least the starting dose is the standard dose. And the next question is, how aggressive are you with dose adjustments for covalent BTK inhibitors when facing with toxicities like AFib, arthralgia, and others? And I guess here, I think I would say most of my practice, the dose adjustments that happen mostly in patients who are on ibrutinib, because we have many more patients, long-term follow-up, and these AEs events occur more frequently in patients who are treated with ibrutinib. I think my general practice has been with ibrutinib. There's also data that lower doses of ibrutinib may be okay. So I think if they have significant side effects, I have in the past reduced the dose from 420 to 280 milligram, kind of with the first evidence of side effects. Though I think the guidelines will suggest in the first event, you restart at the same dose. If it happens again, then you kind of decrease the dose. Certainly, I think we see that with the Acala and ZANU as well, and Pirto as well, but I think to a much lower rate. And I think most of the patients have tried to maintain at the full dose. But maybe I will ask Megan and Krish for your thoughts about the second point here.
Yeah, I think it really depends on the toxicity and how severe it is. And it also depends, now we actually do have a lot of different covalent BTK inhibitors, for example. So if a patient, really had a hard time with one BTK inhibitor, for example, there's a lot of data sequencing from ibrutinib to acalabrutinib or zanubrutinib. I think that's another alternative option. Same thing between acalabrutinib and zanubrutinib, acalabrutinib. So there's a little bit more flexibility in the covalent BTK inhibitor space.
Yeah. And I will also say, I think in my practice, I had patients who were, though there is a published data with, ibrutinib failure going to Acala or ibrutinib failure going to ZANU, and also some data with Acala going to ZANU. But I think in the practice, I had patients who are on one BTK inhibitor, and one patient didn't tolerate that, and second BTK inhibitor, beautiful, and kind of vice versa on another patient. So I think there could be you can potentially try a different BTK inhibitor and maybe okay with that. All right, a very important question. What is the benefit of triplet therapy in frontline setting? So the triplet obviously means BTK inhibitor, venetoclax, and CD20 antibody. I guess in some sense, this is maybe referring to the Amplify study where we have a triplet of Acala, Ven, Obin, though we have ibrutinib triplets and ZANU triplets and Pirto triplets in frontline as well, but really in terms of the expected approval, it is Acala, Ven, Obin. So I think that's a bit of a challenging kind of question to answer in a way. If you look at the Amplify study, it's clear the highest MRD rates are with the triplet. if you look at the unmutated V gene patients, that's the group of patients which is benefiting the most, at least compared to A plus V doublet with the triplet. So I think if I have to choose a group of patients who I may want to use triplet for the best PFS1, it may be an unmutated V gene patients. I don't think for mutated V gene patients, I think Acala-Ven is doing pretty well, so why to add a triplet? So I think, so that's the group of patient, unmutated V gene, younger patients who wants the best deep response for a long-term PFS, potential PFS. I think that's the group of patients where I might consider it. You could argue that you can use a BTK-Ven approach there and reserve your, and then reserve your CD20 antibody for a later use, because I think the PFS2 down the line may be pretty okay. It's a little difficult to say, but so I think for unmutated V gene, maybe there's a case for a triplet. But Krish, your thoughts about that?
Yeah, no, I agree with you completely. And I mean, I think to some extent, this question is also going to change as the duration of therapy changes. So we have, different durations of doublet-based therapy. Does the triplet allow you to further shorten therapy? I think that's an area where we don't yet have clarity, but it may make sense for some patients. I mean, some patients will have autoimmune cytopenias or autoimmune complications. I think those are patients where it makes sense. But I tend to agree with you, Nathan, which is to say, I think we have to remember the bar has already gotten so high with the doublet of the BTK BCL2 antagonists that I think sometimes maybe we're splitting hairs a little bit. And I do have some concerns around toxicity for that population. And so I think it's a really informed conversation with a subset of patients.
And I think the toxicity point is important because if only the efficacy was fantastic with triplet and the safety was the same as doublet, then I think triplet will be the way to go. But certainly, adding obinutuzumab adds to the infusion reaction, also adds to the neutropenia rate. So I think those are the two big ones. So I think triplet is certainly more toxic. I would say, but yes, you get a better MRD rates, which is leading to better PFS. So I think it's a discussion with the patient, especially for younger patients in their 50s and 60s, healthy, who are unmutated V gene patients. I think that would be a discussion with them. We can do a triplet versus a doublet. All right, another big question here. How do you use MRD testing to guide treatment duration decisions with time-limited therapy in CLL? So I guess the point here will be that all the approved regimens, including Ven-G and the upcoming Amplify data, are practically 1 year of combination therapy. So there is no MRD-guided decisions to be made there. But I think in our clinical practice, and again, this is clinical practice, and there is emerging data that you could use MRD to increase the duration of therapy or add a second year of therapy. We have done that in some trials at MD Anderson. I will show you the data from the FLAIR study in a bit, where they kind of use MRD-guided directed as well. But I would say it's not a standard right now. It will be very difficult to become a standard in the community setting to do an MRD-guided stoppage. But I think in academic setting, at least in my practice, I have used it, but I would say that's not the standard because the phase 3 studies have used really a fixed time interval because it's very difficult to, I guess, develop those kind of assays and a kind of and do the trial based on that. Krish and Megan, your points about MRD briefly.
Yeah, I think I'm with you, Nathan. I think we're seeing more MRD driven prospective studies, so we'll have a better sense of how to actually use it, not just as a prognostic marker, but actually as a predictive factor. I think maybe one kind of niche area that I have used it in practice is sometimes there are patients who are on long duration of therapy. For example, I have patients who are on continuous venetoclax alone, and in that setting, if they're having some reason to stop therapy, it's helpful to understand from a prognostic standpoint, but I don't use it routinely in most patients. It tends to be more informative as a prognostic marker.
Yeah. Megan, your thoughts about MRD?
Yeah, I think I agree. It's not standard to use outside of a clinical trial right now. And I think, as we've talked about a lot of the, for example, the MAGIC trial will be an MRD guided randomized duration. I think one important point that we're seeing is it does matter more is not always better. In some regimens, it is. So, for example, the MD Anderson ibrutinib venetoclax, it looked like extending therapy for MRD detectable led to higher undetectable rates. But there's data with venetoclax obinutuzumab that some patients do have some rising venetoclax, rising MRD while continuing venetoclax. So it will have to be regimen specific. So it gets really nuanced and a little bit complicated. So how that will pan out in a clinical setting is still not clear.
So I think in that sense, I think as Krish you mentioned, I think the MAGIC trial will be important to see when that gets reads out, because there is a MRD guided beyond 1 year. And I would say many of the trials, at least the phase 2 studies, many times single center studies, are doublets and triplets, have this provision of MRD guided extension of therapy. Ours and other studies are doing that. I think, but the larger phase 3 studies, most of them have been fixed duration, but I think we'll have some data maybe in the next 1 year or so.
And maybe just to make a comment on the point Megan raised, which I think is really important. I mean, kinetics matter, right? At a binary endpoint, if you're going to use MRD as a one-time landmark endpoint, you have to have very, very high sensitivity, right, to be useful as a surrogate marker. But on the flip side, if you're using it periodically, you have to have a high specificity for positive MRD, right? So the level has to be substantial enough to predict clinical relapse. And so I think this is where we sometimes use the term synonymously, but it isn't really the same. It's done differently in trials. It's different kinetics of MRD achievement in, say, unmutated patients versus mutated patients, and all of that actually makes it more complicated.
And also another thing, I think MRD is such an important point. So I think also the depth of MRD, right? So most of the clinical trial data, you will see MRD4 being reported by flow cytometry, or some people have done NGS MRD and they report -4 data. But certainly if you can get -5, -6 data. So if I have a patient who is finishing VenG for the sake of discussion at 1 year mark, and you happen to do a next generation sequencing assay in the blood and it shows 1 cell in a million, are you going to extend the treatment? Or what if it showed 90 cells per million, So I think that becomes challenging. That most of the data is with flow or -4. So I think that also adds some more complexity, I think, as we kind of think about MRD. All right. Is there a rationale for trying newer time-limited combinations with next-gen BTK and BCL2? So this next-gen BTK, kind of inhibitors, so I mean, I guess we have the 3 in the front line approved. We also have, obviously, pirtobrutinib, we have nemtabrutinib. There are some other investigational BTK inhibitors ongoing. Also, in terms of the next-gen BCL2, we have at least 2 which are in phase 3 studies, including sonrotoclax and lisafdoclax. So I think I would say, just briefly, certainly I think there is a role, and these trials are already ongoing and are in phase 3 studies. We'll have to see eventually how they pan out, non-covalent BTK inhibitors in the front line, next generation of these BCL2 inhibitors versus venetoclax, to say, in the front line. So I think right now, kind of the jury is still, I think we don't know right now, but I think certainly they are being investigated, and kind of the time will tell, hopefully in the next kind of few years, how they kind of pan out. And then we have a question from a community center in Michigan. Does using time-limited BTK venetoclax upfront decrease the chances of resistance and make a stronger case for retreatment? So this is actually a very good, important point, because one of the common questions that get asked is that if you're going to use all your best drugs upfront, BTK, BCL2, CD20 antibody, and if a patient were to relapse down the line, what are you going to go for treatment? So have you, finished all your 3 drugs upfront, and then what are you going to do next? And for this, I would say that there have been several studies, including the Captivate study, including our study from MD Anderson, and I'm sure there's other data, where at the time of progression, when you check for the BTK mutations, BCL2 mutations, PL3 gamma 2 mutations, practically none of these patients have those mutations, and you can retreat them with the BTK, BCL2, or for that matter, CD20 antibody. So you do not gain resistance when you're using a time-limited approach. It's very different from patient on single-agent acala or ZANU or ibrutinib who is progressing. So I do think that when you are using a time-limited approach, the issue of these mutations and the resistance will become less of a concern that way, because you're going to use a 1-year therapy or maybe some MRD-guided therapy. And practically no one relapses when they're getting doublets or triplets at that time. It's really later on they kind of relapse. Maybe I'll ask Megan your thoughts about that retreatment.
Yeah, I agree. There's just not time to develop resistance. And then there's also the issue of, I mean, even say with a BTK inhibitor alone, it takes years often to develop these resistance mutations. And then with the BCL2 inhibitor mixed in, they just don't appear. I think the question will be what retreatment should be. So will it be, there's data, for example, from Captivate of ibrutinib monotherapy. There's some studies looking at BTK BCL2 doublet retreatment, or you could even get venetoclax obinutuzumab in the relapse setting as a fixed duration therapy. So I think some data on that hopefully will be forthcoming. I think at EHA there's some data about BTK BCL2 in the relapse setting, and that'll be really important as these regimens move up front.
All right, I think maybe we have, okay, so we're done with the questions. So maybe in the next 5 to 10 minutes, let me go through some of the frontline data, some important slides or the data sets we kind of already alluded to, but give you a flavor of what the data set currently stands. So this is from the NCCN guidelines. As you see on the left side is the first line therapy for non-del17P patients. And then on the right side is the del17P patients. Practically, it's kind of the same, really. When obinutuzumab and when plus acala plus obinutuzumab are kind of the preferred regimens. And then you also can do acala plus manasobin and zanubrutinib, which have been there for a while. So the new addition to the NCCN is the amplifier regimen when acala plus obinutuzumab, and kind of the same. You may think that, okay, why is that regimen added to the 17P? Because amplifier study did not include 17P, and I believe the NCCN guide group felt that based on the AVO data from Matt Davids, and that this would be appropriate to add there as well for clinicians to order that and insurance companies to cover that. Very important thing to highlight is that it's a question which gets asked often, is that when your patient progresses on whatever therapy they were on, do you repeat the genomic markers again? And the recommendation would be that accept the IGHV testing, because IGHV for an individual patient never really changes. They will always be mutated IGHV or unmutated IGHV. But 17P status, P53 mutation status, and certainly complex karyotype can change. And you can acquire worse abnormalities with time. It was more relevant, I would say, strictly on the chemotherapy era, but I think the same thing does apply to a certain extent, to target therapy era. So the recommendation would be to test them each at the time of relapse to make sure they have not acquired one of these P53 aberrations. Now, we briefly talk about 17B status, and we mentioned that continuous BTK inhibitor therapy is the current kind of accepted standard. And so what is the data surrounding that? And some of the data with the continuous BTK comes from the large data sets are listed here. We have a pooled analysis from a acalabrutinib study, about more than 300 patients. And this was kind of, the 5-year PFS was, I think, around 70% on that. And then we also have a prospective study. So zanubrutinib has a prospective data in the Sequoia study where 111 patients were treated with 17P deletion. And again, the 60-month PFS, as you can see in the middle of the slide, was about 72%. So very similar data between the two. One is a prospective trial, another one is a pooled analysis of multiple studies, but kind of 5-year PFS of about 70% if you use a BTK inhibitor in a continuous fashion. Obviously, one of the major focus in the CLL world these days is the growing experience, what we're talking about, the BTK BCL2, as we kind of just discussing. So let's talk about some of the major regimens which are coming along. Now, this is an update which will be coming out at EHA in about 2 weeks. This is from the abstract, which is already public. This is a 5-year update of the CLL13 study, which compares the triplet of ibrutinib, venetoclax, plus obinutuzumab with Ven-G, Ven-R, and chemoimmunotherapy. And I think the point, and we'll see how the abstract they present in a couple of weeks, but for the first time, they're showing that GIV, the triplet, versus GV, the Ven-G, there was a PFS, significantly improved PFS with a hazard ratio of 0.61 and the p-value of 0.04 in favor of the triplet versus Venji. However, they caution in the abstract that no overall survival benefit, and again, as we discussed before, more toxicities. And so I think we'll see how they kind of relay that. But this is the first trial I saw where the triplet versus Venji, which is a very accepted, obviously, time-limited standard, they're showing that triplet is actually better for PFS. We'll see how the subgroup analysis and other analysis read out. Now, this one is, I think, a very important trial, which is the FLAIR data. Again, this is from the abstract at EHA. So I think EHA is very important. You guys should go to EHA. Very important CLL abstracts are coming through. So this is an update of a FLAIR study. We have seen many of times this update of this trial. But this is the first time they're comparing I plus V, which is 2 to 6 years of therapy. So this is not 1 year of therapy. This is not 2 years of therapy. This is 2 to 6 years of therapy based on MRD in the blood. So much longer I plus V. And they compared it to continuous ibrutinib monotherapy. So the top, the blue bar is I plus V, as you can see, and the green is IV, not IV, is ibrutinib monotherapy. And as you can see, the 5-year PFS for I plus V is very impressive, 94% in a phase 3 randomized study, which is pretty impressive in my opinion. Significantly better than 80% for I. And then notably, overall survival also in favor of I plus V with a hazard ratio of actually 0.41. So I think we'll see the full data set in a couple of weeks, but I think this really makes a strong case for actually MRD-guided I plus V versus continuous ibrutinib, which has been kind of a very commonly used standard all over the world, especially outside the United States. We talked a lot about the AMPLIFY study. This is the data set I'm sure you have seen, came out at ASH last year and then in New England Journal, which showed for all comers AVO was better compared to chemoimmunotherapy. Also, AV was better compared to chemoimmunotherapy. And when we start talking about 17p status, and we talked about the continuous BTK inhibitor, right? That's kind of the de facto standard, but there are emerging data with actually doublets and triplets. Smaller number of patients, but so this is a very important study, Zanu plus venetoclax. This is a prospective trial. About 80 patients were enrolled. And you see what was presented at EHA last year, overall response rate, but just brand new from this morning, apparently, we have an updated slide where the data was presented today, where you can see overall response rate is like 98% on these patients. And practically everyone is responding. But here, Zanu-venetoclax is followed by continuous zanubrutinib. So it's not really a time-limited approach at this time. Now, Matt Davids has been doing the AVO triplet, which is a Calaven Ubin, and it's also MRD guided. You do 1 year. If you're MRD positive, you get a second year of AV. So it's not strictly a 1-year therapy. And he has 45 patients on the left side, 45 patients with the PIF3 aberration. And as you can see, very high rates of MRD in these patients. And the 4-year PFS, which is at the bottom of the slide, 70%. So think back, I told you 5-year PFS with Acala and Acala, Zanu, and also ibrutinib is about 70% for 17p. Here, 4-year PFS is about 70%. So kind of in the similar ballpark, but again, difficult to make big conclusions based on, one study. And this is the study which Jake Samurai has published. This is the BeOne study with Zanu triplet. Again, 39 patients. They did use relatively short duration of therapy. Actually, most of the patients did only 8 to 9 months of therapy. So this is a relatively short duration of therapy. And they reported high rates of MRD negative remission as well on these patients. And I think they have a retreatment allowed for MRD positive patients. And most of the patients are doing well, but again, several of these patients have restarted treatment because they were MRD positive during follow-up. Now, in terms of some of the important aspects of using BTK inhibitor therapy, I think we just wanted to highlight for you the standard dosing, which is listed on the slide here, and also I think safety considerations, which I think for BTK inhibitors, I think you're well aware, bleeding complications, hypertension, infection, diarrhea, arthralgia, and importantly, atrial fibrillation. This was a question asked in the meeting, in the Q&A before, what is the debulking, duration? And I would say that in the ibrutinib studies, people have used 3 cycles of debulking, though if you look at the amplified data with acala-ven, they use 2 months of debulking. So I don't know if there's a right or wrong, but at least, depending on the regimen you're using, you have to think about that. Very briefly about what's coming next. We talked about the MAGIC trial. So this is a trial comparing AV versus VenG in an MRD-guided fashion where you get 1 year of therapy, but if you are MRD positive, you get a 2nd year of therapy as well. We'll see, hopefully we'll hear the results of this trial, which will be very important in the field, comparing AV versus VenG time limited. Also, another important trial, which is in the frontline with novel agents, including sonrotoclax, is the Celestial study, which is sonrotoclax versus ven-obinutuzumab, which is fully accrued, and now kind of we are waiting for the results of that, and that is, bringing this next generation BCL2 inhibitor in the frontline setting for CLL. Also wanted to show this our data from our center where we're using pirtobrutinib, venetoclax, and obinutuzumab in frontline CLL. This is the data we reported at ASH with the clonoSEQ or next generation MRD assay, where you can see very high rates of 10 to the power minus 6 remission, which is highlighted in the dark blue, both in the blood and marrow at serial time points of the study. So I think towards the end, closing consideration for modern kind of treatment, and I think a common question gets asked is, as we kind of discussing in the Q&A session, what patients to consider for continuous BTK therapy. I would say, continuous BTK therapy has the longest track record, has most patients in the world has been treated with that. So certainly a suitable option for older patients, those with comorbidities. I think certainly excellent data in 17P patients, as we kind of discussed. Maybe a good option really for bulky nodes, high creatinine, patients with logistics issue. We're talking about using of venetoclax. So if you have difficulty administering venetoclax, certainly continuous BTK will be the way to go. And to make a point that 2nd generation BTK are preferred than ibrutinib due to tolerability. In terms of the time-limited approach, whether you're taking about VenG or you're talking about acala-ven, I think fit patients, certainly on the younger side, I would say less than 80, though relative age to say there, with the goal that you can have long treatment-free remission. Certainly VenG, we have the 6-year data and have the longest track record. With the Amplify, we have 3-year data, but hopefully with time we'll see more data in that regard. But we certainly have much longer data with I plus V combinations. And I think it's important to discuss both those options to the patients and to counsel patients, again, how this treatment works. You do a lead-in. For the first 2 or 3 months, it's the same BTK inhibitor, and then you basically add venetoclax to the mix. All right, so hand over to Krish. Thank you.
Hey, thank you so much, Nathan. All right, so I'm going to talk a little bit about what are our options for therapy when we go beyond frontline therapy, and where do we see the use of really non-covalent BTK inhibitors in cellular therapy. But we're going to go through some questions first, and so these are really to get at, what are people asking in relapse refractory CLL? So, first question, how do you choose between available options for double exposed but not for refractory CLL? And then what changes if they're double refractory? So I think here we're getting at the idea that people can have been exposed to 2 agents, BCL2, BTK inhibitors, not progressed on them, done well, and then potentially how do you kind of account for that? So maybe, Megan, I'll ask you, what are your thoughts in that setting? And Nathan, maybe I'll ask you about double refractory.
Yeah, I think this is a really important concept, and we even have started to talk about it as in the last section in the frontline setting. So especially using BTK BCL2 inhibitor doublet up front or the triplet with obinutuzumab, patients will have both targeted agents, but they discontinue the treatment for completing the therapy, and that's the plan. It's not that they're resistant to it or had progressive disease during the treatment. So one of the questions that we'll have to answer as a field is what, duration of remission is, acceptable before recycling. With venetoclax, people have said 2 years. There's some data actually, though, with venetoclax retreatment that even between the 1 to 2 year mark might be acceptable. So I think that's one thing to think about, what that remission duration was. And I think around 1 to 2 years, but that would be pretty short if we're talking about the frontline setting. It's going to be a lot longer. So this is really more for the relapsed patients.
And I would say for double refractory, patients, the options, and we'll discuss those. Certainly, I think so. These are the patients who have failed covalent BTK inhibitor and have failed venetoclax and kind of refractory to them. They may have a BTK BCL2 mutations. So I think really the options are you have to move to a non-covalent BTK inhibitor. In the approved setting is obviously pirtobrutinib. We also have liso-cel as the CAR T cell therapy. But these are also the patients where really should be going to a center which have access to other clinical trials, including what we will hear about the degraders and the bispecifics, including for selected patients, I think, allogeneic stem cell transplantation, but not just in the double refractory state, but if they really have progressed further along as well.
Yeah, I think you guys summarized it beautifully. I'm not going to go through this entire slide, but I think just as Megan mentioned, 1 to 2 years is a concept. I think we haven't really settled on what it is. If we think about median, time off therapy for frontline regimens, it's a lot longer than that, right? But we have to be able to operationalize some kind of definition to look at this. So for those patients who are double exposed, perhaps retreatment, and we'll talk a little bit about some of the retreatment data. For those that are double refractory, need to move into a different class. So perhaps non-covalent BTK inhibitors and cellular therapy for now, and later on other modalities. So another really important question that comes up is about intolerance. And so here's a question. My patient is on a BTK inhibitor, is older, IGHV unmutated, complex karyotypes, so some biologic high risk, but has good performance status and has been doing well on ibrutinib for a long time, but was having issues with AFib, switched to acalabrutinib, was initially responding well, and now several years later experiencing some bleeding and infection risk. So, not progressing, has been on covalent BTK inhibitors with good disease control for a long time. Is this somebody where we want to stay within the class? And so maybe I'll say, I think for a patient who's been on 2 covalent BTK inhibitors, has developed different intolerances, but is still responding. I mean, it's an interesting opportunity. I would say one option is to actually see how the patient does without any therapy. And so that's something that sometimes, we know from the days where we only had 1 covalent inhibitor, you can stop therapy entirely and watch those patients. But for a patient where, has high risk disease and maybe you don't want to do that, can we go to another covalent inhibitor? Should we go to a non-covalent inhibitor? These are the things we think about. Megan, what do you think here?
Yeah, I think there's a lot of options here, and I agree. It depends on the disease state. So, like Krish was mentioning, there's data from ECOG 1912 where patients were treated with ibrutinib and rituximab, but many patients stopped not for progression of disease. It was planned as a continuous therapy, but it was almost a median of 2 years before patients needed another treatment. So, I think that's a really great point if it's a toxicity that requires interruption. I think it also, if this patient really does need other therapies, if the bleeding were really serious, there is the option of BCL2 inhibition. Sometimes I found in my practice, logistically, again, it can be challenging with the venetoclax ramp up. So that's a conversation with the patient. And then non-covalent inhibitors have a very low overall, less data out there, but still low discontinuation rate for adverse events. So that's something to think about if you're able to monitor carefully.
And Nitin, I might ask you briefly, would you try a 3rd covalent BTK inhibitor in this setting?
I probably will give a treatment-free remission here, treatment holiday for this patient. And as Megan, you mentioned, I think patients can do very well for several years, actually. And then if they start progressing, you can certainly, at that time, try Ven-based regimen or something else, But yeah, I would be worried about just going for a 3rd for intolerance in an 83-year-old patient, yeah.
Yep. So another question here, is there any benefit to checking for BTK mutations other than the need to switch covalent BTK inhibitors, and how important is it to test? This is a question from our community colleagues in Chicago. So I think really getting around mechanisms of resistance, we recognize these are well defined for covalent inhibitors, but I think the question is really asking, how do you operationalize that in practice? Is it something we should be doing? Do we know what to do with it? Should it really be clinical progression that drives a change? And so what are your guys' thoughts here? Megan, you've done a lot of work to help us define these mutations across the spectrum of BTK therapies. What do you do in your clinic?
Yeah, I think this is a really important question. So I think a lot of the work that has been done shows it's important to understand what's going on in terms of development of resistance and then clinical progression. But especially with work that's been done on covalent BTK inhibitors, we know these mutations can arise during continuous therapy well before clinical progression. And so I feel pretty strongly that whether you check or not, I think it's not standard. I think it can be helpful in some circumstances, but you should not switch treatment just based on the presence of these mutations. So even if you have a patient on a covalent inhibitor like acalabrutinib, they have a BTK mutation present. If they're not clinically progressing, I would continue on the covalent inhibitor until clinical progression. And I really think that if we were to switch just for the presence of mutations, we would be shortchanging patients on the current line of therapy.
And Nathan, for that patient who has clinical progression, do you use that information to then select next line of therapy?
So, I think this is where I think up until recently, since the PIRTO resistance mutation kind of came about, I think maybe there was a sense that if it's clinically progressing, what are you going to learn from a BTK mutation? Because I'm going to anyway switch to a BCL2 or something else, right? I mean, but now we have an option of going from one BTK inhibitor to another BTK inhibitor in a different class. And I think I think still an area of research in terms of the pirtobrutinib, that if I have a patient with a non-cysteine 4 mutation, um, because Akala and Zanu are in about 10 to 20% of the patients can develop this pirto resistance mutations. If I have a patient on Akala who's progressing, and if I were to check a BTK inhibitors panel, maybe they have a cysteine 481S, but maybe they have one of the other 474I or 528W mutation. Is that the patient then going to pirtobrutinib? So I think that's the story we don't know. At our center, we do check at the time of progression. I would think that if you are developing these kind of non-cysteine fluorescent mutation, that may sway you to choose a different path in that sense. But I think that's something we need prospective data in that regard. What is the activity of maybe non-covalent BTK inhibitors in patients who have a priori some of these resistance mutations?
Yeah, I think it's an important point because some of those mutations that we see, T474I and L528W, they may be present in a very low allele frequency, right? So in the Bruin trial, we recognize you could detect those in patients who had C481S mutations, but they were not the predominant clone. And yes, they do seem to expand, but you might get a lot of time on a covalent inhibitor. So I think you're exactly right. We really need a way to sort of identify what's the significance level at the time of switch. And it may not be, at the time you're switching from covalent to non-covalent. It may be at some point during therapy on the non-covalent, but patients can certainly respond to non-covalent inhibitors even with the presence of low-level mutations outside of 481S.
And I was going to say that, I think physicians who treat CML, there is a very well-established ABL kinase domain mutation that if you have a T315I mutation, you cannot use dasatinib, you have to use ponatinib or asciminib or whatever. But I think that kind of I think thinking with these new BTK mutation, I think of maybe that's a CML landscape, but I think still we need to learn more before we can be that prescriptive in terms of what you need to do for this particular mutation.
Yeah, so maybe informative for now, but not something we're necessarily using for therapy decision-making. And so in what scenarios would you consider dose adjusting pirtobrutinib? For example, would age alone or a very elderly or frail patient influence your starting dose or prompt earlier adjustments? I'll maybe answer this by saying I think pirtobrutinib is extremely well tolerated, and so I think frailty alone or age would not be a reason. I mean, there are some suggestions for dose adjustment in patients with renal impairment, but I would really follow the package insert here. It isn't, CLL is a disease of older patients, so they're pretty well represented in our clinical trials, and I wouldn't make any a priori adjustment just based on frailty. And then assuming you have used pirtobrutinib as a bridge to CAR T, could you potentially re-challenge with pirtobrutinib after subsequent post-CAR T progression? I think this is a great question because we hear that concept a lot, and so maybe the exposure is short and people aren't actually progressing on pirtobrutinib. What do you think, Nitin, here?
So I guess the argument here is you're using pirto just as a bridge. You give CAR T, you stop pirto, and I guess you're saying that whether you can re-challenge if they progress, and I think they should be sensitive to pirto, I would think. I think an important question in the field is, can you just use pirto like maybe through the CAR T, post-CAR T, maybe as the liso-cel plus ibrutinib trial was done? But I think if you use pirto for a short duration around CAR T, you stop it, patient progresses 1 or 2 years later, I think certainly they should be, I would think they will be sensitive to pirtobrutinib, and you should be able to use pirtobrutinib again.
Yeah, good point. Not an area where we have data, but
Yeah.
certainly one where intuitively that makes a lot of sense. And then this is an interesting, I think, maybe comment and question. 1 in 5 patients can be cured with CAR T, and so maybe we should ask: is that the right way to think about the efficacy of CAR T cell therapy? Is that how we frame outcomes? I think what's being referenced here is the complete response rate. Around 20%. Is that really equivalating to a cure? And if so, which patients do we prioritize as ideal candidates for cell therapy today? Megan, maybe your thoughts.
Yeah. So I think cure in CLL is always a little bit in the eyes of the beholder, because there's, some maybe functional cure with, prior regimens, but is the CLL truly cured? Maybe is still an outstanding question. With CAR T, I usually don't think about it quite in this way, just because the follow-up is so still short from the liso-cel data. Certainly looks like that 20% of patients, if you get the CR and you're in that group, you have durable responses, I think is what we can say. But I don't frame it to patients in terms of being a curative therapy. I think, in terms of what the ideal candidate is, this is the hardest thing, I think, in the clinic for these patients after a BTK BCL2 inhibitor where they're really refractory, and you're talking about pirtobrutinib and CAR T as your standards of care. And we're going to talk about that data a little bit later on. There has been some data looking at, how do we select these patients out, presented by Bill Weirda. And we saw that bulky disease, is a higher risk factor, higher LDH is a higher risk factor, but we still don't really know what patient and disease characteristics, aside from those two things, which maybe represent, disease control going into the CAR T, will predict for better outcomes. So this really hits on an important research question.
Point. So I'm going to answer this final question, and then we'll go through a little bit of the data to support some of the answers here. Concerns over late toxicity with CAR T cell therapy in CLL. I think this is always a concern with CAR T cell therapy, and most settings that we use it in, we recognize there can be some rare late toxicities that we need to monitor for. I think in CLL in particular, I really think about secondary malignancies as being perhaps different, because that's a risk that our patients carry even outside of the use of CAR T cell therapy, in particular immune suppression related skin cancers, which unfortunately, if you've ever had to manage that in one of your patients, can be really, really challenging in heavily immunocompromised patients. So I think this is something that we need to really be proactive about and be vigilant about and monitor for. But I wouldn't say that it prohibits my use in a patient where, I think we recognize that there is a potential risk benefit here. So just briefly, when we think about second line therapy, these are the guideline recommended options. And a lot of what you're going to choose is going to depend on what therapy patients had in the frontline setting, but can include continuous BTK inhibitors. You'll see obinutuzumab here. We don't actually have data in the relapse setting, but we recognize that obinutuzumab outperforms rituximab in almost all clinical trials that we've studied that in. So there is the preference, but certainly rituximab based on the Murano trial is there as well. And some data for combination BTK, venetoclax as well in the relapse setting. But largely, this is going to be influenced by what the experience was in frontline setting, and pirtobrutinib may be an appropriate second-line therapy, especially in those maybe for whom it might be used as a resistance or intolerance drug, and we certainly have the BeOne 321 data as well, which demonstrates its activity there. But I think what we're going to focus on a little bit more is really this group of patients for whom there's truly refractoriness to BTK inhibitor or venetoclax-based regimens. And here we highlighted, we do have liso-cel as a cellular therapy option for these patients, and pirtobrutinib, and then a host of other options, largely many things which are not very effective, but you may be forced to use if patients have otherwise used all available therapies and don't have clinical trial options. Very, very briefly, I'll just touch on this concept of retreatment for patients who have had fixed duration therapy. We have data from the Murano trial now with the 7-year follow-up of a small cohort of patients retreated with Ven-R. And what you can see here is, they do respond. Around 70% of patients respond. The median progression-free survival was 23 months. Megan published data on Real-world outcomes looks very similar, roughly speaking, around the same overall response rate, roughly speaking, around the same median progression-free survival in patients who had had prior venetoclax-based therapy. So certainly retreatment seems to be a reasonable option for some patients, and we need more data here, especially in the post-BTK ven or post-BTK BCL2 coupled therapies. We have a little bit of that data as well from the Captivate trial. And so you can see here fixed duration I plus V, patients who then relapsed who either got I plus V or single agent I. And you can see in both circumstances, right, patients did do well and responded to a component or both components of therapy. And so, this is again suggestive to the point raised earlier that we don't really see resistance mechanisms, the traditional resistance mechanisms emerge with a fixed duration approach. There may be other resistance mechanisms that are not accounted for by mutations alone that would affect BTK or BCL2 antagonists. And then finally, just another example of this from the HOVON REVEAL trial. So recognizing, again, patients who get VEN-G, VEN-R, who are relapsing can get a BTK ven-based therapy. So in this case, acalabrutinib and venetoclax given for up to 24 cycles. And again, we see a very high overall response rate. And I think importantly, also the potential for very deep responses in a subset of patients, around 21% of patients who actually achieved uMRD status at 10 to the minus 4. So retreatment certainly seems like a viable option, and how we're going to balance this with other therapies is going to be an important question, one we don't have answers to today. Just to remind everybody, the data that supports use of pirtobrutinib, our first non-covalent BTK inhibitor, comes from the BeOne trial. I'm not going to go through all of these data, but we see, again, in a heavily pretreated patient population, including subsets of patients who are BCL2 and covalent BTK exposed, we see high overall response rate, and you see the median PFS differs a little bit based on exposure history, probably a surrogate for biology. And then if we look at patients who have had intolerance to BTK inhibitor, here we see, again, very high overall response rates and the ability to kind of maintain disease control in the class with a median progression-free survival of 28.4 months. That data was published this year in Hematologica. And importantly, most patients who were switched to pirtobrutinib for intolerance did not have recurrence of that same AE. So again, suggesting that we can stay within the class with a switch from covalent to non-covalent. This is the data that was presented by Jeff Sharman at ASH. This is the randomized study to look at pirtobrutinib in the relapse refractory setting compared to idelalisib or BR. This was a global trial. These were patients who were very heavily pretreated, including many who had had chemotherapy exposure in the frontline setting, so biologically a distinct group of patients. And I think that colors how we look at this. So certainly the patients did better than with pirtobrutinib. Median progression-free survival is 14 months. I think if you look at these data in patients perhaps who had different exposure history, we might expect there are probably going to be different outcomes, but this is the population that the trial enrolled. And I think importantly, when you look across subgroups, we know that there's enrichment for high-risk biologic features in the relapse setting, like P53 abnormalities. Most of these patients are IGHV unmutated, and you can see that the point estimates in the forest plot all align on the side of pirtobrutinib. Importantly, when we think about clinical functional endpoints, time to next treatment, I think, is a very relevant endpoint in the clinic. We talked about patients who can have progression, but not necessarily need immediate therapy. And so time to next treatment kind of captures this endpoint, and you can see a substantial difference in patients treated with pirtobrutinib compared to the control arm in BRUIN 321 shown here. And then another important factor for our patients with CLL, we know they're going to live long time with these diseases, and quality of life is important. And you can see a substantial maintained improvement in symptoms, or I should say quality of life related to symptoms due to CLL over time with pirtobrutinib. Just shifting gears to CAR T-cell therapy, these are the data from Transcend CLL. And, I think what we recognize is that the greatest benefit to this therapy really occurs in the patients who achieve deep responses, right? So the patients, that 20% of patients who achieve a complete response, you can see that flat blue line at the top there. Patients with partial responses still do benefit. And I think here is maybe an area where understanding uMRD in patients with PRs is another way to sort of discriminate potential benefit. But I think ideally most people are hoping to be in that top line. Again, a very heavily pretreated population of patients, many of whom were exposed to chemoimmunotherapy in the frontline setting, and median prior lines, if I recall correctly, of 4 to 5 lines of therapy. So very challenging population. Again, if we were to look at this in an earlier disease setting, perhaps we'd see different outcomes. So when we think about recommending therapy to patients and the choice is really between a non-covalent BTK inhibitor and CAR T, how do you operationalize this? I'd first say it's not mutually exclusive. Like sometimes you're going to use the non-covalent inhibitor on the way to CAR T cell therapy, and that's quite common, I would say. But I think this really comes down to really patient-informed factors, right? What are comorbidities? What is the caregiver availability for a patient to potentially go through cellular therapy? What is their appetite really for fixed duration treatment approach, right? CAR T cell therapy is that. It's another fixed duration treatment approach, which potentially can lead to time off therapy. But I think, again, importantly, when you get down to this point in the line, patients have had a lot of exposure to other therapy, and their risk for things like infections or prolonged cytopenias may be substantial. And so ultimately, I think this really comes down to issues of feasibility and patient preference. I don't think we really can look at the data and say that by efficacy, one is superior to the other. Certainly, they've not been compared to each other. And a lot of times in reality, we're going to go from one potentially to the other. And so this is not a mutually exclusive scenario, but one where patient-informed factors are really critical. And so, if we think about examples of patients that we might think about where maybe there's a slight lean to one to the other, here on the left side, we see an older patient, double refractory to covalent BTK inhibitor, BCL2 inhibitor. Perhaps their performance status is declining, has some comorbidities, really wants all oral therapy. I think, you can see here, this is a great case for a patient who's probably going to be on pirtobrutinib as a what we'll call destination therapy, right? Not a bridge therapy to CAR T cell therapy, but on the other hand, somebody who's a bit younger, fitter, has the appropriate social support to navigate CAR T cell therapy, can travel to a center that delivers that, and really values time off therapy. That person is probably the ideal CAR T cell candidate, and in reality, they may get some pirtobrutinib on their way to CAR T cell therapy. So just to remind us, this concept of double exposed versus double refractory is really important, I think, in therapy selection. Certainly, retreatment is a very reasonable option for double exposed patients, and we'll have to see kind of how do we make sense of the best potential options for patients. And I think, like we've learned in many other settings, this is really going to be driven by patient-informed factors rather than necessarily the trial data that we have. And there are not likely to be comparisons of some of these therapies, like, for example, cellular therapy to targeted therapies. I think we'll turn it over to Dr. Thompson.
All right, so I do want to highlight the CLL Society's Clinician Resource Library. This is a really great resource. They have actually not only clinician resources, but also patient-level resources to help inform both providers and patients about CLL. And you can actually request a welcome kit, and the website cllsociety.org. There's an abundance of handouts, fact sheets, and other information. So we're going to talk a little bit with the remaining time about what comes next in CLL, some of the drugs in development, and some preliminary data here. So to kind of go even beyond CAR T cell and pirtobrutinib, which is really great, the pace of progress that we can kind of be having this next discussion. The first question we got was, do BTK degraders offer the potential to overcome resistance to both covalent and non-covalent BTK inhibitors? So I guess I'll just start off with an introduction to BTK degraders because these are relatively new, and we'll review some of this data, but basically it's staying with the same target, but a new mechanism of action. So the degraders, there's several in clinical development, basically bind BTK. They then typically bind E3 ligase on the other end, tag BTK for proteasomal degradation. And so they actually degrade BTK, and the drug is recycled throughout. So Krish, what are your thoughts kind of on BTK degraders and how you view them in terms of patients who are resistant to covalent and non-covalent inhibitors?
Yeah, I think they're a really exciting class. I mean, we've seen some data already from clinical trials on patients who have progressed after covalent and non-covalent inhibitors. We recognize they have a very high level of activity there. And I think importantly, they work kind of as we expect, right? So clones that you would expect to be resistant to, say, covalent or non-covalent inhibitors, they're able to eradicate. I think one of the things we don't yet know, right, is the duration of response to these agents and what that's going to look like and what the mechanisms of resistance will be to those drugs. But I think they're really exciting for that population of patients.
Yeah, I mean, I think I agree. I mean, I think the data suggests that they will be, I think whether it's a cysteine 481S or one of the non-cysteine 481S mutations, I think the degrader seems to be working across the board. But as you show the data, the follow-up is still 1 year or less than 1 year, depending on the study you look at. So I think we really have to see how, next 1 or 2 years go with that in terms of duration of remission.
Yeah, and then the other thing that we'll talk about is BCL2 inhibition. So right now, venetoclax is the only FDA-approved BCL2 inhibitor. We've seen a ton of data incorporating venetoclax, really venetoclax serving as a backbone. But there's some emerging data that we'll review about newer BCL2 inhibitors. I don't know if you have any thoughts on that.
Well, I think there's no head-to-head comparison yet or reported yet. So I think the arguments there, I guess the rationale there, I think there is some postulate that maybe some of the new agents do not, G101V, the mutation, they kind of circumvent that. They may have a better PK profile that you may see less neutropenia, which has been an issue with the venetoclax in a way. They have a different ramp-up schedules, which are trying to be simplified or confusing, but anyway, simplified. So I think, but I think those are the rationale to make it easier to deliver. But I think we'll have to see how maybe the randomized studies see.
And here we have a case. So I have a heavily pretreated patient with relapsed refractory CLL, several high-risk features, including complex karyotype, deletion 17p, declining performance status, pulmonary comorbidities, and progression on prior treatment with ibrutinib and venetoclax. Currently doing well on pirtobrutinib, but what is the next step? And this is from a community colleague in Georgia. So Krish, how would you kind of think about this patient? They've had ibrutinib, venetoclax, and pirtobrutinib, and what are the plans for the future knowing their comorbidities?
Yeah, I think Nitin highlighted this earlier. When you get to this stage, you really have to have a plan. And I would say, this is a patient who it sounds like coming from a community center, trying to engage with a center that has clinical trials or potential cellular therapy. I mean, we can take frail or older patients to CAR T-cell therapy, but you have to be very thoughtful about it. To date, outside of CAR T-cell therapy, there isn't another therapy option that we have for a patient in this setting. So I think that's really maybe the take-home point is that probably when you start the pirtobrutinib is when you need to think about the plan for what happens when you progress on pirtobrutinib.
Yeah, I think, Krish, as you saw the data with pirtobrutinib, if you look at the 3-to-1 study or the BeOne study, I think guaranteed those patients were much more heavily pretreated, maybe 4 or 5 prior lines of therapy, and the PFS was 14 months or 18 to 20 months. I think the PFS here I would expect was just strictly a second or third line, whatever setting, maybe better, but still I think you have to start thinking about that. This is not going to be like a 10-year remission or 8-year or 5-year remission likely. So I think, as you said, CAR T-cell therapy, referral to a center with degrader studies, bispecifics, I think that's kind of next in line.
So this is a really interesting question. Will we be able to use bispecifics after CAR T and CLL and vice versa? So we'll talk about some bispecific data in CLL. It is an earlier phase compared to, for example, diffuse large cell lymphoma and follicular lymphoma. I'll answer this. So in the epcoritamab data that's been presented, I believe there's 3 patients who had prior CAR T cell therapy. So we'll have to see more data and sequencing, but I think this is a very forward-looking question. Given the progress with sequential use of targeted therapy into the 3rd line and beyond, are we at a curative point in CLL from our colleagues in Chicago? So I think this is an interesting question. So what do you think, Krish?
Yeah, I think, Megan, you highlighted earlier, right? Functional cure is a term that gets used more and more. Think about the median age that people are diagnosed and the number of lines of therapy that patients starting treatment today is. Some patients may be functionally cured because they die with their CLL, not of it. And so I think we have to be intentional about how we define that term, and there will be some patients who don't need more than 1 or 2 lines of therapy.
Yeah. I think this it's I think what's the definition of cure? I think I think in the leukemia world, in a way, many times people say, at least in the acute leukemia world, okay, if you give a therapy, they're off therapy for maybe 5 years or 10 years with AML or ALL, maybe if you have cured their disease. Now in CLL, I mean, I think if you argue the same, that, oh, you need to have a 10-year remission off therapy, but what if the clonoSEQ, I had a patient recently on a CAR T who's doing well 5 years out. I keep telling them, I think we have cured your leukemia. And then I checked out of curiosity a clonoSEQ, and it came like 4 cells in a million. And I was like, oh, what I did here. So I think now the patient is not cured. I mean, he has a clonal, and I rechecked it. It is there. It's a true value. So I think that's, but I think bispecifics, CAR T, and I think Chris, you mentioned about the cure fraction maybe. I think some of these strategies will definitely cure patients. But what's the cure fraction will be, I think that remains to be seen. But I think we are, I think, not for everyone, but I think for most patients, I think we'll do very well long term.
Absolutely. I think the one thing I'll highlight is that the immune consequences of the disease, more study needs to be done with newer treatments, but that may hang around a little bit, effect on T cells, even when the CLL clone's not there. So I think that's another important point to consider.
And I think on the point what Chris raised, I mean, I think, do you need to cure CLL to live a normal lifespan for CLL patient, right? So I think that's exactly what you said, right? I mean, if they have a clonoSEQ, like flow positive disease for that matter, if they're living normal life, counts are normal, I mean, I think that's fine. So I think that's the challenge.
So what is the tolerability profile of degraders compared with non-covalent or covalent BTK inhibitors? So I'll answer this. Well, there's been no head-to-head data, so and there's a much earlier follow-up, as already was alluded to earlier. So we'll review some of this data in the next segment, but it is an early phase patient population, heavily relapsed refractory, so we don't yet know the answer to this. And is there concern for off-target effects with degraders given their impact on other kinases? So we'll review this as well. So some degraders are more specific for BTK. One of the degraders, for example, NERX-2127, which was the first clinical trial data to be reported for chronic lymphocytic leukemia, did have Ikaros degradation as well. Other degraders don't have this Ikaros degradation. And have we seen any differences, this is a good question, with how toxicities like cytokine release syndrome manifest in CLL with bispecific antibodies versus DLBCL or follicular lymphoma? Chris, do you have any comments here?
Yeah, I think this is going to be different. What we see kind of across the board in lymphoid malignancies, if you have marrow-involving diseases and circulating disease, your risk of CRS does tend to be higher. And I think that's an important challenge we faced in trying to optimize the step-up dosing regimen for bispecifics in CLL. And so I think, we're going to have to be creative and use different approaches to try to de-risk bispecifics in CLL, because it is a different disease biology and a different compartment of where those T cells engage the malignant cells.
All right, so let's talk about BTK-directed treatment first. So to mention, there are other non-covalent BTK inhibitors, other BTK inhibitors that have non-covalent covalent activity, but this is nemtabrutinib. This is a non-covalent BTK inhibitor, and this is data from the BellWave study, which looked at nemtabrutinib in relapsed B-cell malignancies. Across all doses tested, this was the dose escalation trial, there was an overall response rate of 36%. When you look at the CLL patients who were treated at 65 milligrams daily, which was the dose for further study, about 75% response rate. So there is an ongoing phase 3 clinical trial testing nemtabrutinib in combination with venetoclax versus a control arm of venetoclax rituximab in the relapse setting. And then to talk about BTK degraders, so you see 3 listed here, BGB 16673, NERX 5948. and then ABBV-101. There are others in the clinic. We reviewed this a little bit in the Q&A, but basically many of these drugs generally work by binding BTK on one end and then bringing E3 ligase, binding that on the other end, bringing it in close proximity to BTK. BTK gets tagged for proteasomal degradation. So this is data from BGB-16673, the Cadence 101 study, and this will be updated by Dr. Scarfo at the EHA meeting. 66 evaluable patients. The overall response rate is 80%. This is a heavily pretreated patient population, and the dose selected for further studies, 200 milligrams daily, and the response rate at that dose is 94%. It's pretty short follow-up, as was highlighted earlier, but the median progression-free survival, you can see the PFS curve there, has not yet been reached. And this has shown clinical activity in patients with high-risk, traditionally cytogenetic and molecular features such as deletion and or mutation of P53, as well as in patients with various BTK mutations. And here's another data for another BTK degrader, NERX-5948, or bexobrutideg. And this has been reported. You see some really nice data from Dr. Shah's presentation at the ASH meeting looking at BTK degradation, both of wild-type BTK and mutant BTK. And you can see a host of different BTK mutations there in BTK degradation across the board. And then there'll be updated data presented at the EHA meeting by Dr. Omer, and 47 patients with an overall response rate pretty similar of 81%, and all of these actually were partial responses. So looking at the safety data, which I think is really, really important for these early phase clinical trials, here are just some highlights. Across the board, there was either no rates of atrial fibrillation, for example, with BGB-16673, and this is data that was presented at the ASH meeting for both agents. And then for NERX-5948, there was one case of AFib in a patient with pre-existing AFib for CLL. The reason there's no pancreatitis for the BGB-16673 is there were some lipase elevations, but there was no clinical pancreatitis. And then there were some hemorrhage events listed there, a low overall rate of febrile neutropenia. And you can see for NERX-5948, there were overall a very low rate for a phase 1 study of drug discontinuation from one CLL patient. So going into the next generation of BCL2 inhibitors, so we already mentioned and alluded to this because there's an ongoing frontline trial incorporating sonrotoclax, but this is the next generation BCL2 inhibitor, very selective, has a much shorter half-life than venetoclax. And this is data presented at that was presented last at the EHA 2024 meeting, looking at sonrotoclax and zanubrutinib in combination. There were different ramp-up schedules, so a daily or weekly ramp-up, and then the median follow-up at this point was 19 months presented on. And so this is really looking at 8 to 12 weeks of a zanubrutinib lead-in, and then in combination with sonrotoclax. And this data will be presented in a couple weeks at the EHA meeting, and it is in relapsed refractory CLL. Patients could have had prior BTK inhibitors, but couldn't have progressed on the prior BTK inhibitor. There was no tumor lysis syndrome seen. Neutropenia was the most common grade 3 or higher adverse event, and a high overall response rate in this setting at 96% with a complete response rate of 50%. And high rates of undetectable MRD. You can see MRD4 levels or UMRD4 levels in the green, and it looks to deepen over time. This is a continuous regimen. Here's another BCL2 inhibitor, so a novel oral BCL2 inhibitor, lisafticlax. This actually has a different ramp-up where it does a daily ramp-up schedule, so more of a rapid ramp-up to get to the target dose. And this data was most recently presented by Dr. Davids at the ASH meeting, And there was a cohort looking at monotherapy activity, but also in combination with acalabrutinib. And the efficacy in the relapse refractory setting as a combination therapy was quite high, 97% when combined with acalabrutinib. And I will highlight that there were a couple of patients who had had prior venetoclax-based therapy included in this study. So here, in terms of bispecific antibodies, switching gears, is data presented by Dr. Danilov with the epcoritamab in the relapse refractory CLL setting last at the ASH meeting. And this looks at the study, which initially used an expansion cohort that pretty closely, in terms of at least the dosing of the step-up dosing, modeled other lymphoma studies going from 0.16 to 0.8 to 48 milligrams. And then there's more recently been an optimization cohort to try to mitigate cytokine release syndrome and ICANS, adding an additional week of step-up dosing, as well as more requirements surrounding dexamethasone during the step-up period, as well as hydration. The responses have been quite good in both cohorts. I will say the optimization cohort is short follow-up, only a median follow-up of 3 months at the last presentation. But overall response rate around 60%. This is a very heavily pretreated patient population as well. I believe it was a median of 4 prior therapies and a median progression-free survival of 13 months in this cohort. And I think the safety data is really important here because it does appear to be a little bit different, as was alluded to earlier, than other lymphomas in terms of the incidence of CRS. You can see in the expansion cohort, that was the initial cohort that did not have the dexamethasone. It did have some steroid requirement, but not the same steroid requirement as the optimization cohort. The majority of patients did get CRS. Most was grade 2, but there were 16% of patients who had grade 3 CRS. And then when the optimization schedule was put in place, at least thus far with this preliminary data, there has not been any CRS. Most events do occur at the first full treatment dose.
We are kind of right on time, but I think if there is one or two questions from the floor, we'll be happy to take those before we close. I'm looking at the online questions which were submitted. I think we answered a lot of them already, but maybe I'll ask, this is a slightly different question, but this is about CAR T-cell activity in the context of Richter's transformation. I know we talked about CAR T-cell Krish, so maybe you want to comment on what your experience has been in the CAR T for Richter's?
Yeah, I think it's a really important therapy option for patients with Richter's. Amongst the therapies that we have, probably leads to some of the best outcomes. I will say it's not a perfect therapy in that setting, and so there are still some unanswered questions around what's the best strategy to kind of maintain those responses. Should patients get consolidated with things like allotransplant, which is what we used to think about in this setting? So certainly a necessary and needed tool. I think I'll also just highlight that drugs like pirtobrutinib actually also look good in Richter syndrome, and this is another area where I think bispecifics may have some role as well. So more to come there. There's still a lot left to be done to kind of optimize care for those patients.
Got it. And I guess there's a question, this is more about the BTK intolerance. So for BTK intolerance, what do you recommend for a transition period to another BTK inhibitor? Do you switch immediately, or I guess you slowly transition the patient? I guess just a BTK intolerance to, let's suppose, a ibrutinib. What's your strategy to moving to maybe Acala or Zano?
Yeah. So this kind of hits back on the point we made earlier. I think it's a really great point to evaluate whether a patient can have a treatment-free remission and actually needs to go on to that therapy. But for patients who truly do need to, say they're early in therapy, or their disease burden is such that or they have a history of flares where they have to transition, I usually just transition the next day. The half-life is relatively short, and I don't take a break, but curious what others' plans are.
And I think on that note, I think one important point is that there are some of the patients who are on a BTK inhibitor and they're kind of failing BTK inhibitor, and let's suppose you're thinking of a next line of strategy, maybe a Ven-based strategy or going to a degrader or whatever trial. I think some of these patients, if you stop a BTK inhibitor, they can progress very, very rapidly. Within a matter of days, their LDH will rise, the lymph nodes will worsen. So I think it's very important that if you are, I think this is something maybe you didn't realize maybe 5-6 years ago, but now I think most of the trials have a very short washout of BTK inhibitors, and I think it's important in the clinical practice to kind of be mindful of that. There's a question for patients with many high-risk factors, complex karyotype, unmutated V gene, 17p at baseline, but also a very challenging clinical situation, multiple comorbidities, advanced age, frailty. What is your go-to strategy for treatment in the first-line setting? Krish?
Yeah, I think here we are fortunate to have second generation and beyond BTK inhibitors. I think most patients can tolerate those very well. And so this might be a patient where, the risks of fixed duration therapy because of things like frailty and tumor lysis and having to come to the clinic and be monitored might not make sense. On the other side of the coin, I'd say CLL14 was designed for patients who are older with comorbidities. So I think, most of our therapies can be safely delivered to frail patients. I think it just has to be very thoughtful. And here I think also the strategy of BTK plus BCL2 antagonist is useful because you can modulate the time that people are on the BTK inhibitor before you introduce the venetoclax to try to lower that risk and not have to use any antibody-based therapy. So.
And Megan, your thoughts about this multiple, very high-risk patients with multiple comorbidities, elderly patient, what's your kind of strategy for those patients?
Yeah, I think the deletion 17p in that question does sway me probably towards the continuous BTK inhibitor, but I think this is where some of the newer data will be really important because I think in the past, a lot of us have been, despite the excellent point that was made about CLL14 being designed initially for elderly patients, and it can be done, a lot of us have used continuous BTK inhibitor in that setting. But seeing the flare data, I think of the I plus V versus the ibrutinib monotherapy alone, and that overall survival difference is going to be really important to tease that out in a little more detail. And, we'll have ongoing trials in the field too, looking at continuous BTK inhibitor versus fixed duration in a little bit different way that might, sway us a different way in the future.
Yeah. All right, fantastic. So now we have come towards the end of the session. So thanks everyone for spending your Saturday evening at ASCO with us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, CLL Society. This activity is supported by educational grants from BeOne Medicines and Lilly. To access all materials for this activity, visit peerview.com/BFB860.